Hey everyone, it's Russ from Wealth Care for Women. Thanks for joining us today. I'm excited to be joined once again by Christine from Caribou. For those that aren't familiar, Caribou is my healthcare planning partner, and they have become increasingly involved in my retirement planning and financial planning work with clients. As you all know, healthcare, health insurance is not getting cheaper, and it is increasingly an important part of our financial planning and decision making process. Today, I'm excited to have Christine talk to us about the upcoming Medicare open. Well, actually, it's not just Medicare, but open enrollment period, specifically around Medicare today. But there's a lot to cover, so I'm going to turn it over to Christine to jump in. Thanks, Christine.
Thank you, Russ. I'm excited to dive into this subject. It is the happiest and busiest time of the year for us because it means you can actually make changes to your Medicare coverage. So, like you mentioned, open enrollment actually happens both for the marketplace as well as your employer plan and also for Medicare. But today we're going to be covering exclusively what open enrollment means for Medicare. We're going to go through a few things. First, we're really going to align on the basics of Medicare and why Medicare planning is so important. And then we're going to get into how to pick the optimal coverage, as well as how you can put that plan into action during the open enrollment period and when you need to make those decisions by. So, in terms of the life events that we help advisors support and talk to their clients about, and that are opportunities to review and revise your healthcare coverage, it's much more than just Medicare itself. So, if you have questions because you're retiring, or if you have questions because your COBRA is expiring, or you are moving, these are all life events that you can go to Russ, your advisor, about. But today, again, we are really going to be focusing on that exploring or changing Medicare option. So this is a good webinar, even for somebody who is not yet enrolled in Medicare, but about to transition to Medicare, or who is pretty curious about what Medicare might cost or cover specifically for them. So that's going to be the main focus, as well as strategies for current Medicare beneficiaries to implement during the open enrollment period. And for anyone who is not familiar with what open enrollment is and why it is so important, it's because every single year plan designs change, meaning that there could be different premiums, out of pocket maximums, deductibles, provider networks, drug formularies, preferred pharmacies. All of these things can change year to year. So even if you are staying on the same health plan, you get that renewal notice and you don't do anything about it, it's an auto renew, it doesn't mean that your costs are going to be the same. You will almost definitely have a different premium, and you will probably have different out of pocket maximums, deductibles, provider networks, drug costs, and so on. Not to mention that while all that is changing, your current needs are potentially changing too. So while there's no crystal ball, I want to encourage you to think forward to next year, the year 2024, and what types of services you might anticipate needing. Maybe you've been talking to your doctor about a hip replacement, for example, or you are on the brink of being prescribed potentially a new medication, or you're undergoing different treatments. These are the sorts of things that you want to be considering now during the open enrollment window to align your coverage best with what your needs might be next year. No crystal ball, of course, but if you can have that mindset as we go through this webinar, and as you make your selection for your Medicare coverage during open enrollment, that is the best way to think about it. During the open enrollment period, you have the option, and we'll get into exactly what you can do, but you have the option to kind of rejig your current coverage. And what always surprises me when I say this statistic is about 95% of people who are enrolled in Medicare aren't on the most cost-effective drug plan for them, meaning they're overspending on their drug coverage and they're overspending on their prescription medications. So there is a lot of benefit in reevaluating your coverage, specifically your drug coverage, because your drug coverage is one area where there's no questions asked when you're looking to change it during the open enrollment period. So let's first make sure that we're all on the same page about the differences between original Medicare and Medicare Advantage, because without that baseline education and understanding, it can be kind of tricky to make a change during the open enrollment period. Typically speaking, when you first enroll in Medicare, we like to encourage clients to enroll in the coverage that they anticipate having for the rest of their life. Medicare can get very, very complicated and complex if you are trying to switch around your coverage after you first initially enrolled. For those who aren't familiar, when you enroll in Medicare, you have two options as to how you want to configure that coverage. You have Original Medicare, which includes Part A, Part B, a Medigap plan, and prescription drug coverage, known as Part D. D is for drug. And then you have Medicare Advantage, which is basically an all-in-one option that bundles everything together and often is called Part C. We're going to go through some key differences between these two options, but just so that you know, and I'm going to repeat this throughout this webinar, if you choose Original Medicare, in the future, you can switch to Medicare Advantage no problem during an open enrollment period. But if you want to do the reverse, if you've enrolled first in Medicare Advantage and you want to switch to Original Medicare in the future, you will probably have to go through what's called medical underwriting, and you might be denied that opportunity to switch and get on this Medigap plan. And that Medigap plan is what basically caps your total potential drug costs. So it's pretty risky to enroll in Original Medicare without that Medigap policy. Diving deeper into the differences between the two options, there's three key things that you really want to make sure you understand before making your initial decision or before considering switching. The first one is in costs and basically the risk tolerance associated with that cost. On Original Medicare, in most locations and for most people, you are going to have higher fixed fees, meaning every month you're probably going to pay more in premiums than you would if you were on Medicare Advantage. On Medicare Advantage, though, you are probably, in most states and for most people, going to have higher variable costs, meaning you will pay less on a monthly basis, but your potential out-of-pocket costs are actually probably going to be higher. So this is important to consider as you think about your risk tolerance and your budget and the potential assets that you have to cover your healthcare expenses. And it's one of probably the most key considerations that people think about as they're making that initial selection or thinking about switching in the future. Your premium is what you pay no matter what. It's like your gym membership, whether you use it or you don't, you're going to pay your premium. And again, on Original Medicare, that's typically going to be higher. But your fixed costs, or your variable costs rather, are those out-of-pocket expenses. And as you age, you probably are going to accrue a lot more out-of-pocket costs given your healthcare needs are probably going to grow, the services that you access, the medications, and so on. So that is something that is key to understand, and I'm going to show you side-by-side financial comparisons in a little bit. We will get there so you can visualize that numerically, but at a high level, that's kind of consideration number one. Number two is related to access and networks. On Original Medicare, you have the option to visit pretty much 98% of doctors and facilities. They all accept Medicare, Original Medicare, as payment in full. On the Medicare Advantage side, on the other hand, you have networks, just like how you did with your employer or just like how you did on your marketplace plan if you retired before the age of 65 and enrolled in a plan through healthcare.gov. So you have to be mindful of whether or not you have access to a PPO or an HMO. If you're not familiar with the differences between those two options, a PPO will cap your total costs out of network, meaning you will have benefits in other states and have a total cap on those costs, whereas an HMO is a lot more centralized and you will have a lot more limitations in who you can see, and there are no out-of-network benefits offered unless it's an emergency. I actually looked into Atlanta, the Atlanta area. Russ, if most of your clients are in fact in that area, there are PPO plans available on Medicare Advantage. So that's lucky in that you can have a little bit more flexibility if you do live in the Atlanta area, but you want to check your specific county as well as your state to see what's available based on where you live as you're making that initial selection or considering changing in the future. Last but certainly not least, there's the concept of prior authorizations and potential denials, both of which are a lot more common on the Medicare Advantage side. You might have to get approval for certain services. You might have your claims denied. You might have to appeal them. The rates at which this happens for Medicare Advantage are much higher than the rates at which they happen for Medicare. You can Google this. It's very common kind of in the media right now, as a lot of these carriers are sort of studying the trends happening in this area specifically, and different carriers have different rates of prior authorizations and denials for services as well. So you can actually look into it at the specific level of Aetna or Humana, for example, and see what their actual rates are.
Yeah, speaking of which, as Christine knows, I've shared a little bit about this with her, but I'm kind of dealing with this first person right now. So my mom is on a Medicare Advantage plan, and the short version of a very long story is she's had 3 hospitalizations in the last 45 days or so. And at the conclusion of each of her hospitalizations, when she's being discharged, we have requested, and the hospital has requested, that she go right into a skilled nursing facility for rehab. And on both of her first 2 hospital stays, her Medicare Advantage plan denied the request for coverage. Interestingly, on the second hospital stay, we appealed. She had been home for 2 weeks, and then her Medicare Advantage plan finally approved it. But for a variety of reasons, which I'll spare you, we couldn't get her actually admitted to a skilled nursing facility because she wasn't going straight from the hospital. It's a mess. Anyway, all of this is particularly of interest to me, this entire presentation, and I'm thankful Christine is joining us and going through it, because I am going to work with Christine and Caribou to run a health plan analysis for my mom, probably starting the first week of October, to see if we can get her switched from Medicare Advantage to traditional Medicare. As Christine mentioned, she'll likely have to go through medical underwriting, and because of her hospitalizations, she may or may not get approved, but we're going to absolutely see if we can make that happen. So I just wanted to mention that, since Christine just mentioned the sometimes problematic process with authorizations and denials with Medicare Advantage. I've seen that firsthand.
Thanks for sharing that, Russ. Oftentimes that's the case where people don't realize some of the limitations until, unfortunately, they're faced with, a situation like the one that you're in. So hopefully there's a path forward that offers a lot more flexibility for you and your family. When it comes to either option, both include Part A and B. So there are still the same baseline services for facility-based and medical services. Part A is going to be your facility-based coverage. That's your hospitals, nursing facilities, hospice care. And Part B is going to be your medical services, doctor's visits, vaccines, durable medical equipment, things of that nature. Part A is typically free. If you've worked 40 work quarters or have been married to somebody who's worked 40 work quarters, it's free and coordinated through Social Security. It will be deducted automatically from your account if you're already collecting those benefits. But if you are not yet, when you turn 65, you will have to go and set up that account through Social Security and through Medicare.gov and pay those premiums. Part B has an income-based premium. You can see here on the next slide how that is determined. If you file, for example, a joint tax return, and Medicare will look 2 years back. So in 2023, we are looking 2 years back to 2021 to determine what that premium is. You will follow your income band down, down, down until you hit where you are. Let's say you're in this band. Your Part B premium is going to be $527.50. Again, this would be for this year, dependent on 2021 modified adjusted gross income. And then you'd have $70 on top of your prescription drug premium for your Part D. So Part B, the base premium that anyone would pay is $164.90 this year. And then based on your income, you pay an adjusted amount. Whereas with Part D, you will pay the premium of the plan that you choose. And then on top of that amount, you will pay the income adjustment. So if you're not subject to an income adjustment because you're in this lowest bracket, then you will have no additional cost for Part D, but still this base Part B premium. Next year, which is 2024, they will be looking at 2022 income. So always 2 years back, and also these bands change depending on how you file your taxes. So this is an example for a joint tax return. We do not know yet what the specific bands will be and what the premiums will be for the income adjustments, but Russ will be updated with that information once it becomes available, typically in October or November. With Parts A and B and Original Medicare, that only covers 80% of the costs. So that's why the concept of Medigap plans was introduced. Basically, it is to plug that 20% that Medicare Parts A and B don't cover. This is sold by private insurance companies, so you will have a separate insurance card for this Medigap coverage. And in most states, like Georgia, there are 12 lettered plans to choose from. There are some states that have different systems where there aren't letters. Those are pretty uncommon. If you live in one of those states, feel free to reach out to Russ. We can put you in contact with us to answer any questions you might have about that. But for sake of scale here, the most common are Plan Gs, high deductible Plan Gs, and a Plan N. And there is the F option available to anyone who turned 65 prior to January 2020. It's no longer offered for new people eligible for Medicare, but there are some grandfathered people in who turned 65 before January of 2020. Some things you want to consider is that based on what we see, Plan G is definitely the most comprehensive and probably the most common that we see advisors suggesting to their clients to enroll in. Every letter that is the same letter, like a Plan G offered by Aetna versus a Plan G offered by AARP, is going to have the same identical benefits. So a Plan G is a Plan G is a Plan G no matter who offers it to you. The only difference in benefits is if you go from a Plan G to a high deductible Plan G or to a Plan N, that's where there's going to be a difference in your cost sharing structure. A Plan N, for example, could be suitable for lower healthcare utilizers and people who have a strong preference for lower fixed monthly costs. One of the key differences is that you might have excess charges, meaning you might have coinsurance or copays for different services. So your variable costs, again, going back to that concept of fixed versus variable costs, the variable costs are going to be higher on a Plan N, whereas on a Plan G, it's very, very predictable, and I'll show you exactly what that looks like here in a minute. The high deductible options, again, mostly for a high deductible Plan G, because most people don't qualify for a high deductible Plan F, can also be suitable for people with lower healthcare needs or a lower tolerance for high premiums. But again, you want to be thinking about your coverage long term, as if you were enrolling for the rest of your life, if you are just enrolling for the first time or considering switching. So you can almost guarantee that in the future, you will have higher healthcare needs and probably have to pay up to that deductible. Now, some states do have different considerations, like the states with guaranteed issue rights, for example. If you live in Connecticut, Maine, Massachusetts, or New York, you have what's called guaranteed issue rights, which means that you can actually switch your Medigap plan whenever you want. So you don't have to worry about that medical underwriting and possibly being denied this Medigap policy. So it's very, very advantageous to live in those states. However, you might be subject to a small waiting period, maybe about 6 months. So you don't want to play around with waiting until you potentially get really sick, for example, and then want to switch. There are some states as well that have the equivalent of what a Plan F was, and that's no longer offered too. So if you're wondering about those options available to you and why they might not be offered, it's probably because you didn't turn 65 before January of 2020. So here's a really good example which shows why you wouldn't just set and forget your insurance coverage. This is actually somebody who has a Plan F. They turned 65 3 to 4 years ago. They have a Plan F. They pay about $172 a month for that Plan F. The only difference between F and G is that there is no Part B deductible. You can see $0 here versus the $226 offered in this Plan G option and this Plan G option. But what has happened, and a lot of carriers have done this, is that the premium has increased so much that the total difference, and if you add that premium and multiply it by 12 and then add in that deductible, actually comes in lower on a Plan G than it does on the Plan F. And that's a really common trend. A lot of carriers are trying to push people off those Plan Fs. They want to push them onto a Plan G. But when people don't reevaluate their benefits, they miss the opportunity for those potential cost savings. You can almost guarantee that every single year you're going to hit that Part B deductible. So you can almost, again, guarantee that that is an expense that you will incur. And so you can factor that in and think about the difference in cost if you're currently on a Plan F. The other thing that you will add in is your prescription drug coverage. So you've got your A and your B covers 80%. Now you're going to add your Medigap plan. Now you've got 100% coverage for facility-based and medical services, but now you need drug coverage. So it's not all in one, like it is on the marketplace or like it is with your employer. This is going to be your third card now that you're going to carry around that is offered potentially by a different private insurance company. So you might be enrolled in a Humana Medigap plan, but an Aetna SilverScript Part D prescription drug plan, for example. So you will have those 3 cards that you might need to pull out depending on what services you're accessing. Each individual plan has its premium. They can be as low as $5 or as high as, I've never seen them really go above $80 or so. And there is that income adjustment. So on that table I showed earlier with the bands and then the Part B premium and then the Part D premium, you're going to pay that income adjustment on top of your premium of this plan that you pick. There's no current cap on drug costs, and this is something that's actually going to be changing, as well as they don't accept any manufacturer coupons too. Here you can see a timeline of the Inflation Reduction Act and some of the changes happening specifically to Medicare drug coverage. One of the most exciting things that I just mentioned is that cap on Part D prescription drug costs. In 2025, they will be capped at $2,000, meaning you will not spend more than $2,000 out of pocket on drug costs. And that is a really, really big win because I've seen some clients with $20,000, $30,000, $40,000 in annual drug costs. There's been some changes that have already come out, like the changes in insulin copays, which have been great. And then over the course of the next 5 to 6 years, we will continue to see changes in what specific drugs cost, especially for those really high cost drugs that are now able to be negotiated directly with Medicare. So we'll keep you afloat of all of those different pieces of news as they do come out. It will make life a lot easier for your advisor, Russ, to be planning for medication costs. But again, $2,000, you still want to make sure that you are still optimized because there could be costs that are, $400, $500 for your drugs. So you want to still make sure you're on the best plan possible. Medicare Part D plans also have these funky tiers that as you move through and refill your prescriptions throughout the year, you'll actually have different coverage as you hit different limits. So it's called the Medicare donut hole. And basically before the donut, you will be responsible for 100% of prescription costs until you reach your Part D deductible. So that's the same as any health plan that you've had in the past. You got to pay up to your deductible before your plan pays anything. Once you've reached that deductible, your plan starts paying the majority of costs, leaving you with your copays or your coinsurance until your total drug costs reach what's called the initial coverage limit. And this initial coverage limit is set by Medicare every single year. And so every plan has the exact same initial coverage limit. Most people don't go past this. A lot of people that we see stay below this. I think it's in the $4,000 range, around there. So usually most people are below this. If you have a long prescription list or you take very high cost medications, you might go beyond this and you might go into what's called the Medicare donut hole, where you will pay no more than 25% of the drug. So basically the cost sharing is going to differ between you and the drug company, and it's going to depend on if you take a brand name drug, a generic drug, and the actual retail cost of that medication. So the amount that you pay when you refill your prescription when you're in the Medicare donut hole is going to change. Once you come out of that Medicare donut hole, you've reached what's called catastrophic coverage, where you will only be responsible for the greater of 5% of drug costs or small copay or coinsurance for your medication. So as you go through these different stages, you will have different refill costs for your medications. Again, most people don't go past that initial coverage limit, but costs will differ if you do go past that amount. Here's an example of somebody comparing their prescription drug coverage. You have on the right side of this table, highlighted in bright blue there, the current prescription drug plan, PDP. This example is showing you that here you have costs about $29 a month. You've got a plan $10 a month, $79, $40. Great, maybe you want to enroll in the least expensive option. The bottom half of this table is going to show you the actual costs associated with each of those options. So you want to make sure that you're considering not just the premium, but also the coverage quality for specifically the medications you take. There are examples that I will show you where the same carrier has 2 to 3 different plans where the medication cost on each of those plans is all different. So I won't spoil that. We'll get to it soon. But this just highlights here that you got to look at the actual coverage and costs associated with each medication. In a lot of cases too, maybe the brand name of the drug won't be covered, but its generic version might be covered. If you are going to explore lowering your costs by taking the generic version of a medication as opposed to the brand name, please, please, please talk to your doctor about that first. There might be a reason why they did prescribe the brand name, and so you want to make sure that you get that cleared through them in advance. This is that example that I just teased you with. This is somebody who is on a silver script plan, lowest premium plan on the right-hand side. We see $7.20 is the monthly premium. However, their total estimated drug costs were $40,000. Middle option, $73, total drug cost $53,000. So you can see here, you can pay a little bit more a month to reduce those annual drug costs on an estimated basis. And then additionally, there was an AARP option that was actually more suitable for them. So you want to make sure, again, especially if you've got a long drug list or drugs to begin with, any amount, even just one or two, that you're potentially revising those drug plans during open enrollment. If you're watching this webinar because you are just curious about Medicare, but you haven't yet enrolled, and you're thinking to yourself, well, I don't take any prescription drugs, so I don't need drug coverage, and I'll just enroll in that later on when I do have a medication, please don't do that. The answer is almost yes when it comes to should I enroll in drug coverage when I'm first eligible for Medicare. If not, you will be exposed to a late enrollment penalty, and you might not be able to enroll unless it's open enrollment, and that coverage will not go into effect until January. So if you get prescribed a medication in March, unfortunately, you will have no coverage until January 1st of the next year. Your late enrollment penalty too will be based off of the time that you didn't have coverage. So for every month that you don't have coverage, you will start to accrue that penalty. So the longer you wait, the bigger that penalty will be, and that penalty sticks with you for life. It is an adjustment that you will pay on top of your Part D premium as well as on top of your income adjustment. The only way that we would ever say you don't need to enroll in drug coverage is if you have drug coverage through TRICARE, the VA, or a spouse who is actively employed. If your spouse is on COBRA because they retired, they're not yet 65, they enrolled in COBRA, which is a continuation of their employer coverage for about 18 months. If you yourself are over 65, that does not qualify as credible coverage. You need to enroll in a Medicare drug plan as soon as your spouse stops working. So unless you have TRICARE, VA coverage, or your spouse is actively working and has drug coverage offered through that plan, you need to enroll in drug coverage for Medicare, which again is your Part D. Some Medicare Advantage plans come without drug coverage. So if you have TRICARE, VA, or a spouse's employer plan, you can enroll in a Medicare Advantage plan without drug coverage. If you do not, please enroll in a Medicare Advantage plan that does have drug coverage. It's all embedded, all in one, combining, again, that medical and facility-based services with drug coverage all under one umbrella, one private insurance company, which makes it a lot easier from an administrative standpoint, but again, comes with some of those other limitations that we've discussed. So Medicare planning in general and going through this robust of a comparison is super important because otherwise, advisors don't actually have good tools to help them understand what their potential clients' costs might be. They might be able to plug into their software a certain income, where the client lives, moderate healthcare utilization, and what type of coverage they have. And that might spit out, $6,900 in annual costs. But as you can see with this example, who's a real client that we worked with, this is someone who spent $25,000 a year on drug costs. So you can see individualized, personalized estimates are a lot better, and you can only get that information from actually analyzing your benefits. So we talked a lot about the preferences and potential limitations of both options, but now let's really dive in here into the costs of both options. At a high level, I did explain that you'd have Part A and Part B in both options. Again, both, typically speaking, for Part A have no premium, but you will pay your Part B premium for both Original Medicare as well as for Medicare Advantage. A lot of the times, Medicare Advantage is marketed to be free, no premium, and a lot of people don't understand that they still have to pay that Part B premium, and it is going to have that income adjustment. So remember I mentioned the income or the base premium for Part B was $164. This one certainly has an income adjustment added into that. Additionally, here you will see on the original Medicare side, you're going to have that Medigap policy. You see that it's a premium of about $171, and then you have that deductible. This table shows 233 rather. This year it's 226, but next year it's probably going to get bumped up in and around 233. Last year was the first year it ever went down, or one of the first years in a long time that it ever went down. But we'll probably see it come up this 5 or 6% or so next year. So we kept this for sake of just looking forward into 2024. Then you'll have your prescription drug coverage. You see here, $690 is that premium, very inexpensive on a monthly basis. You've got your income adjustment on that Part D. So all in every month, you pay $550. Add in your expected drug costs. This guy's probably on an inexpensive generic drug. And you've got, $6,900. Very, very similar to what that prior kind of estimate did show. But on the Medicare Advantage side, this actually looks really different. And the main driver for that is this out-of-pocket maximum. Yes, you might not have a premium for that Medicare Advantage plan itself, but you do have the Part B and the income adjustment on B as well as D. And then you have this out-of-pocket maximum, this $6,700 that is much, much different than this $233 in potential out-of-pocket costs. And so that's why, despite your monthly fixed fees being about $372, your total worst case financial responsibility is over $11,000. So that's almost double the amount that you might expect to spend. And so that's a really big difference from a financial planning perspective. And that's why your advisor, Russ, wants to dive deeper into your specific coverage with you and make sure that you are on the best coverage possible. Not only understanding the differences between those two options and the potential costs of those two options, but also, again, because those health plans are changing every single year, these Medicare revisions can actually save you money. Based on the trends that we are seeing with users of our software, we see savings across health plan premiums, prescription plan premiums, prescription drug costs, and then also because your advisor now has insights into what you're spending on your healthcare, they could also potentially offer some guidance in the area of tax deductions too. So lots of great savings and ways to lower your overall healthcare expenses, which make up one of the top expenses with housing and transportation while you are in retirement. Now that we have all the basics covered, I want you to really consider what your top priorities are. We've gone through some examples here that have highlighted the specific costs. We've gone through some examples that highlight potential flexibility or limitations and who you can see. And before you actually dive into open enrollment and are thinking about changing your plan, or again, if you're enrolling for the first time, think about what's most important to you. Is it most of your healthcare providers being covered? Is it a recognizable insurance carrier? Is it lowest monthly fixed cost, lowest total financial risk, plans with a high rating, or keeping your current insurance carrier? Rank these 6 different factors and decide what's most important for you before you even start shopping around. Then as you start to see the options, you can start to refine your preferences. So here in this example, you can see that this option here in the left is optimized for provider coverage. This one here is optimized for recognized carrier, or you might have a lowest exposure option. So you can kind of do this side-by-side comparison and really figure out what might be best for you. I've shown a couple examples of different tables and different costs. That prior one, the original Medicare, definitely aligned with the estimate, but here you can see this one at about almost $12,000 a year is much, much different. And over the course of 10, 20, or 30, or even 40 potential years, that amount certainly adds up. If you're financially planning and using those estimates, you don't want to underestimate what you might spend on healthcare, and you definitely don't want to overestimate too. You want to live your best life during retirement. So as granular as we can get, that's why it's important to really, really evaluate these options and these costs annually. On the Medicare Advantage side, we do see about $15,000 in healthcare costs, but just to show you one example where Medicare Advantage actually comes out on top, in this one we see $8,500 in annualized potential risk versus $94,000. So there are some states, actually, some locations, specifically the county itself, where the out-of-pocket maximum can actually be pretty low. We've seen as low as $500, $1,000, $1,500. And so in those cases, you might actually have the total risk come out to be lower. So it can be the less financially risky option. But again, there are those other factors that you do want to consider. In addition to that, Medicare Advantage will have some other perks that are often quite attractive to people. For example, some vision or dental benefits, fitness programs, transportation to certain medical services. So there are things that they do throw in there that can make it a more attractive offering. Keep in mind that when it comes to vision and dental, if you are on original Medicare, you can buy standalone policies for that. VSP for vision and Delta Dental for dental services would be good options for you to shop around for a few plans and quotes there. And those are just your routine eye care and glasses services and just cleanings. When it comes to like ophthalmology services, for example, that's considered medical. And so that would be covered by Medicare. On the Medicare Advantage side, when you're looking into the options, the tables of comparisons that I've shown so far have been strictly financial, but don't overlook that you also need to look at doctor coverage too. Because Medicare Advantage has those concepts of networks, you want to make sure that the doctors are in network for the plans that you are considering. So even the same carrier can have a potential option that does not include the doctors versus one that does include the doctors. So you want to make sure that you're verifying that not only with us, but also directly with the doctor's office, because they will have the most up-to-date information when it comes to whether or not they are in network for that specific insurance plan. And you want to give them the plan ID, not just the insurance company name, like Aetna, for example. You want to give them the plan ID because there might be different plans offered by the same carrier. And again, the doctors may be in network for one and not for the other. So it's not just strictly about costs. This is the last financial table I will show you, and what it highlights too is if you're watching this because you are aging into Medicare sometime in the future, but you're still actively working and maybe you're actually over 65 or you're planning to work past 65, don't delay the Medicare conversation. Definitely approach Russ, your advisor, to talk to you about Medicare and potentially enrolling sooner. As you can see in this option here, this is somebody, likely a business owner, covering their spouse. They pay about $3,200 a month for their premium. Their employer is not subsidizing any of the costs. And as you can see here, if I just jump to the very bottom, total risk is about $45,000 a year based on that very, very steep premium and the out-of-pocket max. Whereas on Medicare, the costs actually go way down. Here you see this example, it's about $5,000 versus $9,600 on Medicare Advantage. So you can enroll in Medicare if you are still working past 65. Sometimes, and we've seen it quite often, it is actually advantageous for you to do so, especially if your employer is not covering any of the costs. You do want to be mindful, though, of a spouse. If you are the active working participant and your spouse is retired and not yet 65, they could potentially go on COBRA if they have only an 18-month window to Medicare. Otherwise, they might have to go into the marketplace. And so typically, we see very high costs for people on the marketplace, so you don't want to make this decision in isolation. You want to make it considering any, ripple effect it might have on other members of the household too. So now that we have hopefully a very, very good understanding and foundation on what Medicare covers, now we can get into what specifically you can change to kind of drive us home here in the last few minutes of this webinar during open enrollment. Open enrollment runs from October 15th to December 7th. So you only have a quick sort of less than 2 months to change from a Medigap plan to a Medicare Advantage plan. Again, if you're going Medigap to Medicare Advantage, no questions asked. But if you are going Medicare Advantage to Medigap, there's medical underwriting. Additionally, if you just want to switch your Medigap plan, maybe you want a different carrier, underwriting may be required too. If you just want to switch your Medicare Advantage plan, no questions asked. You can do that every year. Or if you want to join, switch, or drop a Medicare drug plan, no questions asked. You can do that every year. Just want to repeat this statistic because it's very important. 70% of Medicare beneficiaries don't revise their drug plans annually, and 95% are on a plan that's not optimized to their current prescription list. So please, please, please do at least look into your drug plan. That is one of the things, again, no questions asked, that you can change if you're on original Medicare. And if you're on Medicare Advantage, same thing applies because that coverage is embedded within that plan. You might want to look for a more cost-effective option. All of those changes are effective January 1st of 2024. Here you also see Medicare Advantage has its own enrollment period that runs a little bit longer, January 1st to March 31st. You have a full 3 months to switch your Medicare Advantage plan. So you can do that during both periods. And you can also drop your Medicare Advantage plan and return to original Medicare, plus join a separate Medicare drug plan and Medigap plan. But again, for that Medigap plan, you will probably have to go through medical underwriting unless you live in one of those states with guaranteed issue rights. When it comes to the drug plan, no questions asked, but you don't want to risk potentially not having that 20% gap that parts A and B don't cover. What you can't do is you can't switch from original Medicare to Medicare Advantage. You can't join a Medicare drug plan if you're on original Medicare, and you can't switch your Medicare drug plan if you're on original Medicare. So the safest thing to do is basically to make all of your changes in November. So if I could encourage you, if there was just a few takeaways from this webinar, if there is one thing that I can encourage you to do, is that if you are looking at optimizing your coverage, evaluate those options and make your changes in November so that you do not have to worry about any potential deadlines that you might miss or forget about, especially as the end of the year and holidays and everything are upon us. And with that, I will turn it over to you, Russ, if you've got any questions that you think your clients might have, or if you want to just wrap us up and we can end the webinar.
Yeah, thanks, Christine. This was great. You covered a ton in a relatively short amount of time. And I know that anyone watching this will probably have some additional questions about how this relates to their personal situation or their family situation, or to their financial plan. As Christine mentioned, I'd encourage you to reach out to me. I would be happy to help you evaluate your coverage and cost options with the help of Caribou, Christine and her team. It is work that I've been doing more and more the last couple of years, and have found instrumental in making my clients' plans more personal and more accurate to their situation. One quick question I'll ask you, Christine, as we wrap up. I know you covered a ton here, and this is kind of a subjective question, but in your experience, what have you found surprises most people about the open enrollment period when they're either evaluating Medicare for the first time or revisiting their current coverage?
That's a great question. I I think no matter whether it's potentially less expensive or more expensive than they thought, typically people are shocked by the cost. Some thinking, "Whoa, this isn't as expensive as I anticipated," or "Whoa, this is a lot more expensive than I anticipated." It's very rare that we get kind of a neutral reaction of "This is exactly what I expected." Which is why we do really encourage more proactive planning, and why we're really grateful to have the opportunity to work with you, with clients, well in advance of their initial enrollment period. I think a lot of individuals don't necessarily understand kind of the back end workings of insurance, the potential incentives, and all of the changes that can be made. So that set it and forget it kind of mentality is quite common. And, it can be a really big surprise to them to see a big premium jump. But if that premium jump, hits you in January because you threw out that renewal notice and didn't look at what that premium was going to be, unfortunately, you've missed your window of opportunity to shop around. So really, again, just encourage everyone to look at and evaluate their options during the month of October or November. November, again, is that safe month where you can do it the whole month. That way you make sure that you can get those changes in and not be surprised about potential costs. That's hopefully what we're trying to do here, is help people make very confident and clear decisions about their coverage in a way that is really proactive and not necessarily, reactive or surprising in the future.
Yeah, thanks for that. And to reiterate comments you made just now, as well as throughout the presentation, even if you've got what you consider great coverage and you feel like you're paying a fair cost for it, it's really worthwhile to review your coverage every year, especially your drug plan. As Christine mentioned, things change, costs, coverages, formularies, all sorts of things, and they're going to continue to change going forward, even with the expected drug cost cap coming in 2025. So even if you're a Medicare veteran and are happy with your coverage, it's still worthwhile to review your coverage. Make sure you do have the best combination of cost and coverage for your particular situation, your drugs, your doctors, your pharmacies, in your overall health circumstances. So, Christine, thank you again. This is super helpful and super timely as we are knocking on the door of open enrollment. As I mentioned, if anyone has any questions or would like to discuss Medicare or health, your health insurance or health planning needs, reach out to me and let me know. I can, with the help of Caribou, help you get those questions answered. And Christine, thanks. Until next time.
Yep. Thanks, Russ. See you soon.